So that is the end of my presentation. This is my contact information for anybody on the webinar who's interested. And I think now we will take questions.
Yes, thank you so much, Dr. Sterling and Eileen. We'll begin answering questions submitted during today's presentation. Moderating the questions today will be Eileen Sue.
Thank you, Kat. I have actually quite a few questions starting to stack up here, so let's get right to it. We do have a question about fibrinogen levels. Do you monitor patient fibrinogen levels during the procedure?
Okay, so this seems to be a very common question. The answer to this is we do measure fibrinogen, but really the only reason we do that is I do work in a 5-hospital health system. And for all of our thrombolytics, PE, DVT, and acute arterial occlusions, all of our order sets have to include fibrinogen as being drawn. However, we do not use the fibrinogen to impact therapy for PE, mostly because these are about 12-hour-long infusions, and by the time you would potentially, and you usually would not see any change in fibrinogen, your infusion is over. So yes, we do measure it, but no, we do not. It does not impact our treatment for PE.
Great. Some technique questions now. Post-therapy in the unit, when you're starting to take the PA pressures, do you adjust or move the catheters, or are the pressures taken exactly where the catheters are situated?
So good question. So we pull the microsonic core and do it as I said earlier, and we hook it up to a transducer. Now those catheters are usually in the lower lobe pulmonary arteries. It does happen. It is uncommon where you have a wedged pressure where the distal tip of the catheter is really wedged into one of the pulmonary, into a distal pulmonary artery branch. And so usually we do get a tracing, but they do slowly, withdraw it. And you have 12+ centimeters of length of the catheter. So even if you pull it back a little bit, we are measuring it there. And that's the thing that we did when we were comparing the EKOS catheters, like just hooking it straight up to the transducer, maybe pulling it back minimally, measuring the pressure, and we did correlate that with the pressures we measured through Swan-Ganz catheters and pigtails, and found that there was a even correlation. Yes, the answer is we do it. We do pull it back slightly to make sure we're not wedged in a branch. But once we start getting the tracing, that's a pretty consistent tracing that we have to the main, the right pulmonary artery.
Great. I have a question about how many hours post-therapy do you follow with EKO?
I'm sorry, ask that again?
It's like how many hours post-therapy do you follow with EKO?
So usually, if somebody has that, we have those pressures, so we don't repeat the EKO right at that moment. We will like to usually get an EKO before they go, they get discharged. It is nice to have a baseline EKO before they leave the hospital, which we do. So it's not like we needed an emergent EKO at that point in time, because we do have the pulmonary pressures, and I think that you'll have even if they're in the hospital another day, you'll have some further improvement, and so usually they'll get it prior to discharge.
Great. This is a perennial question. Do you place,
if there's any clinical change in the patient, that would be the reason we would also get an EKO. Next question.
Okay. Yeah. Do you place filters in PE patients?
The answer is, the short answer is no, we do not. We don't routinely place filters. Now, there has been some evidence that in a massive pulmonary embolism, it may not be unreasonable to place a filter for those patients. But we do not routinely place filters, certainly not in the submassive pulmonary embolism patients who we're going to treat with lytic therapy.
Okay, great. A lot of curiosity about that last patient that you talked about. If in that last patient who did not have a difference in pressure changes, would you consider surgical thrombectomy?
The answer is absolutely. So in a patient like that, that is exactly where I would be trying to refer the patient. We have had patients who have had no improvement in the acute phase, and then this patient did get referred to the pulmonary artery hypertension clinic, and then referred for evaluation for surgical thromboembolectomy. In our experience, and I know some hospitals are very fortunate, surgical thromboembolectomy in the acute setting has not been something that we have had, a lot of interest in from our surgeons. It just is something that a lot of hospitals don't have interest from their surgeons, but certainly for chronic patients who have that kind of a picture, that would be a very worthwhile consideration.
Great. Do you have a question about your PERT program in a way? Who is called first when these patients are present in the ER? Is it the pulmonologist, IR, surgery, cardiology? How does that work at your hospital?
So we do have, in essence, I think the most famous PERT that I think a lot of people hear about is the Mass General PERT. When we got interested in doing this, like I said, a little over 6 years ago, we had an interest in this. It was really just coming onto the scene, or really just talked about really sporadically in cases. Prior to that, we had been doing, we didn't do EKOS lysis with this kind of a protocol, and the only PEs we got called for were patients who were really crashing, and we did only massive patients, and we would do, clot maceration and different techniques. But when there had been some interest in possibly using EKOS or other multi-sidal infusion catheters for PE, we called a meeting with all the potential people who would be interested in treating PE. So that included cardiology, pulmonology, interventional radiology, surgery, cardiothoracic surgery, all these different subspecialists, ED, of course. And at the end, the only people in our institution who really had significant interest was pulmonary critical care, ED, and interventional radiology. So in essence, that is our PERT team in our community hospital. ED will typically generate the initial phone call. These patients are sick. We do have an intensivist who's going to be that doctor who's going to take care of the patient. We get called by ED, and we get called by pulmonary critical care if this is somebody who we're being asked to consider therapy. So that's our PERT team, and I do say this to people, you don't need to have 10 different subspecialties to have a PE response team. In every hospital, it's going to be very different. Really, as far as the catheter person, it's who's ever interested in doing those procedures. In some places, it'll be vascular surgery, cardiology, interventional radiology. It really is whoever's passionate about treating these patients. But most of those calls do come in through the ED, and if they do come in through the ED and they make it upstairs and, they're a submassive patient, we frequently will get called by our pulmonary critical care colleagues.
Great. It's always good to hear about how PERTs are done in different facilities, and yours is a particularly interesting one, I think. Have a question about the dosing of the TPA. How about bolusing TPA before initiating the drip?
So we do not do that. We have not found it to be necessary, certainly with the submassive, because we see the benefit that we've seen in really most all of these patients after that infusion without having to bolus. The only patients who I guess you would consider for a bolus, but it's not like they're getting, this is not something we're doing routinely, and it's very rare, is the patient who's really kind of crashing, and you've made the decision to give them systemic TPA, say in the ED, because you don't have that time, or you don't feel you have that time to bring them to the lab. That's that patient who's in shock or something like that, and they do get their systemic TPA, and if they're going to get the 2-hour infusion, that dose starts, and let's say it's been now 45 minutes or however long, and they've gotten part of the dose, and they've kind of stabilized a little bit. there has been discussion, and we have had patients who they've now stabilized a little bit, and we have brought them to the lab to do even a modified EKOS lysis protocol. So they're not getting the full 100 milligrams of TPA. They are getting something lower. But on a routine basis, for those patients who are, like I said, stable, massive, or I'm sorry, relatively stable, massive, and all the submassive patients, we don't find the need to bolus. We just start the infusion. And I'll, like I said, I invite all of you to await the results of the Optilize PE trial, which will be presented in May, which talks about different dosing regimens and the effectiveness of those different doses and infusion times.
Okay, great. I'll have one more of these chat questions, and then we'll go to the raised hands questions. So it's one about patient selection. The person is asking, what is your threshold or cut for RV-LV ratio for significant RV dysfunction requiring EKOS? And they were asking because your fourth case had an RV-LV of 1.1. So,
right. So actually, I think it was the third or fourth case. So in that case, right, less than 0.7 is normal. Greater than 0.9 is that value that has been associated with mortality in some of the anticoagulation and systemic thrombolysis protocols. So, there's been in the ICOPA registry, if you had greater than 0.9, that was associated with 30 and 90-day mortality. Now, we are making a bit of a leap when we're taking those conclusions and treating some of these submassive patients. However, if it's in that 0.9 to 1.1 and they're very stable, those are patients that we will admit to the ICU, give them their supplemental care, O2 or whatever, and we'll observe them. And in some of those patients, by morning, they may even look better. And then those are patients we do an echo on. And if that RV-LV on the echo now, although we don't repeat the CTA, if now it looks more normal, then those patients will just be anticoagulated. So we're not those are the submassive patients that we are observing and not treating. Now, if we had somebody in the 1.1 to 1.2, 1.3, and they had a PESI, a simplified PESI score of 1 or 2, we might trend on treating them earlier than observing them. And the reason, as I stated, is because some of those features are associated with increased mortality. And there's something about a patient who, although normotensive, all of a sudden, and unfortunately many people have seen these patients where they come in, they look pretty good, they may have some RV dysfunction, but they're okay, and then all of a sudden they flip, and you may not have all that time to bring in a team or do some kind of escalation of therapy in a timely fashion. And so if they're very tachycardic early on, then that might be somebody we would trend on treating earlier. So I hope that answers the question. We do observe some of these patients for sure, but we do use an S-PESI index to sort of raise or lower our threshold for earlier treatment.
All right, so EKOS would like to thank Dr. Sterling and the participants for attending today's webinar, Interventional Treatment for PE, Tips and Techniques. Once you leave today's webinar, you will receive a survey for the presentation, and we would appreciate it if you would complete it and provide your feedback. On behalf of EKOS and Dr. Sterling, thank you very much for joining us today.